can we have the next slide? Okay. So we have a very prestigious judges with us, sir. Next, please. Dr. Smita Singh, she is the director of MGIMS, Maharashtra, and presently she is working immensely in entry segment, mainly phacoemulsification and refractive surgery, having lots of national and international publications and awards. Next, please. It's a proud privilege.
That's mine. Proud to introduce JB sir. So we have all been his students. We have learned so much from him. Always a pleasure to be wherever he is. This is too small. I think tomorrow when he's getting the Lifetime Achievement Award, you'll hear the whole gamut. He's been the one nicest people in Shankar Netralaya whom we all look up to, always smiling. And he looks very absent-minded. Don't even believe that. He knows everything. He's organized, disorganizedly organized, very, very organized. He'll remember each person's name. He'll remember what homework he's given you, what work he's told you to do. Don't even think you'll run away not having done it, come whatever you may.
In fact, he is one of the best mentors. Like, he taught me how to write a paper, how to write the results, discussion, conclusion. Sir, you made me work in lymphangioma. I still remember.
Mine was malignant melanoma, sir.
And today I have got more than 130 publications, sir. It's only because of you. You mentored me, sir. Next, please.
Yeah. Dr. Naresh Babu. Sir is in Arvind Eye Hospital, Madurai. He did his MS Ophthalmology from JIPMER, Pondicherry, and then went on to the Arvind Hospital, Madurai. He's been associated with the Orbis International, has many publications, more than 56, and would have actually delivered more than 60 lectures.
Sir is a great
Pleasure
mentor, sir.
You.
Many of your students, they are working in Sri Shankara Deva Netralaya, and I'm so happy, like every time we discuss about any topic, they'll say, yes, I mean, Naresh Babu sir told us this. So thank you very much for being an amazing mentor, sir, to many of the upcoming ophthalmologists. Next, please. Sir, it's a proud privilege to have you, sir. Like, I was trying to find you, and morning when I have seen your photograph, I was so impressed, sir, when I have gone through all your awards. Sir needs no introduction. He is a very renowned VR surgeon from Jammu and Kashmir, sir, right? And he had received all the prestigious awards and very much known in the ecoin. He has done tremendous work in community ophthalmology. Before meeting, sir, I have heard his work, like in community ophthalmology. And he has received multiple Best Paper Award, and also, most important, he has received a Bopara Award for his work on trauma. So really very happy to have you with us, sir, today. And also, sir is with us in tomorrow's evening program, and that's a surprise. We'll not tell you what is the program. Requesting all of you to join us tomorrow at 8 p.m. Next, and there should be Rangini madam and Lahani sir, no?
Next slide.
Next.
Dr. Sudipta Mitra. Madam's here.
She should be here. She was in the morning. She looks more like a senior resident than like a judge. Very dynamic and very good surgeon, a very good orator. And she is doing tremendous work in basically entry segment. Received multiple awards, both national and also international. Next, please. I should take this privilege to introduce my very dear friend, Dr. Vinit. In fact, Vinit is such a good soul, such a good person. When I was there doing my fellowship at Shankara Netralaya with my two daughters, the younger one was only 3 months, elder one was 2 years. So Vinit and his better half and also Rashmin and all helped me so much in getting the baby's food. And they used to help me like how I was bringing the daughter when I was doing my fellowship. I'm always obliged to him for all the help he had given me in that very important phase of my life. So Vinit is an excellent, I should say, he's a glaucoma consultant, and one of his biggest achievement that he had started Shankara Netralite Kolkata today, which is running so good, like it is his baby, I should say. He and Dr. Mrs. Tratra received a very prestigious the D.B. Chandra Award for the best paper in glaucoma and multiple national, international, including the AIOS-ARC award. And he's a prolific surgeon. I have seen him operating live, and he's a very good anti-semitic surgeon. And also, he has a very nice sense of humor.
Can we go to the next, please?
Next, please. Lahane sir needs no introduction. He's a founder, chairman, and he is one of the best mentors from Maharashtra, a very humble and a very good mentor. He's a Padma Shri, and also he has multiple achievements and awards. And sir is not here, no? I have seen him. I think he's on the way. He's coming. Next, please. Dr. Ragini also needs no introduction, has performed more than 80 surgery. She is very humble, very soft, and a very nice person, and has done extensive work in community ophthalmology. She is, I think, the present president of the Bombay Ophthalmological Society, and she is very friendly and a very good mentor to many of the upcoming ophthalmologists. We are just waiting for the final results, and once it comes, we'll start the session. We could have taken the lunch. We were running. Couldn't take it. Okay, she'll be the first presenter, and what the judges are Jyotirmoy Vishwas sir, Naresh Babu sir, Dr. Tariq Qureshi sir, and then Sucheta, okay, Sucheta, Vinit Ratra is there, Dr. Ragini madam, and Vinit. Lahane sir, and should we start? Can you show the slides of the rules and regulations? Do you have the slide? It's a same. Yeah, 4 minutes presentation, 3 minutes discussion, and it will be marks are on the basis of 4 categories. One is the concept, originality, use of statistical analysis, and also the scope of likely publication. So please stick to your time, because there may be negative marking if you do not stick to your time. So I think we should start the first speaker. The first speaker is Hitusha Mittal.
Good afternoon, everyone. I'm Dr. Hitisha. I'll be presenting my thesis titled Rescue of Conjunctival Lymphatics with Retinoic Acid after Mitomycin C-induced inhibition in rat eyes. We all know that post-trabeculectomy bleb drainage is via aqueous veins and episcleral vessels. However, studies have shown the presence of lymphatic channels in the subconjunctival blebs, and studies have also indicated the cytotoxicity caused by mitomycin C on these draining bleb channels. Further literature research led us to this molecule retinoic acid that has lymphangogenetic properties and is being explored in experimental animal models. So we came up to this question: can we counteract the MMC-induced damage to lymphatics using retinoic acid? So we designed this study with the objective of seeing the effect of MMC on these lymphatic channels and to see the effect of simultaneous application of MMC and retinoic acid on these draining channels. It was a prospective experimental animal study done on 30 Sprague Dawley rats, which were divided into 5 groups. In each group, the right eye was the intervention eye and the left eye was control. In group A, the intervention was done with balanced salt solution. In group B, with mitomycin C. Group C was the dose standardization group for retinoic acid. We started with 10 nanomole concentration, but due to lack of effect, we increased it to 100 nanomole. Group D was the combined MMC and retinoic acid group, and Group E was the DMSO group. After weighing the rats and giving intraperitoneal anesthesia and under sterile aseptic conditions, we used a 30-gauge needle to cause localized injury in the subconjunctival area and made a superior subconjunctival bleb as per each group specification. On post-op day 14, the eyes were enucleated and the excised conjunctival specimens were analyzed in pathology lab with CD31 and D240 markers. We saw the presence or absence of these immunohistochemical markers in the specimens, the lymphatic and blood vessel density, and the effect of MMC and retinoic acid on these draining channels. Appropriate statistical tests were used, which led us to the following results. There was a significant reduction in the MMC group in the conjunctival lymphatic count. However, the combined MMC and retinoic acid group had a dramatic increase in the lymphatic count. These are the histopathological slides. We can see the first one is the normal lymphatic density. Second one is a post-localized injury density. Third is the MMC-induced decrease in lymphatic density. And the fourth one shows a dramatic increase in the lymphatic count after combined MMC and retinoic acid application. On blood vessel analysis, we found that the combined group also had a higher blood vessel count when compared to the MMC-treated group. These are the histopathological specimen slides of the same. In the first one, we can see the normal blood vessel density. The second one is an increased blood vessel density after localized injury. The third one shows decrease in blood vessel density after MMC application. And the fourth one shows an increase in the blood vessel density after combined MMC and retinoic acid application. So to conclude, MMC has a toxic effect on the conjunctival lymphatics, and this can potentially contribute to bleb failure post-trabeculectomy. Retinoic acid has a lymphangiogenic and angiogenic property at 100 nanomole concentration, and simultaneous application of retinoic acid and MMC can reduce the MMC-induced inhibition of lymphatic and vascular channels. These were the merits and demerits of my study. I would like to thank my mentor, Professor Pandav sir, for giving me this opportunity of doing this study. Thank you, everyone.
Any questions from the judges? In the meantime, the next speaker is Dr. Saurav Haral, Nishi Prasad, Anupam Singh, Jayadev Nanda, Hirika Gosalia, Pragya Ahuja, Shalin Shah, Parvati Narayan, and Nilima Matthew. So these are the selected papers. Saurav Haral, are you there? Okay, you be ready, sir. Any question? Yeah. Yeah.
Thank you, sir.
Good afternoon, everyone. I'm going to present my thesis to evaluate the efficacy of tacrolimus versus topical interferon alpha 2B in vernal keratoconjunctivitis. My guides in this thesis were Dr. Taskin Khan ma'am and Dr. V.S. Gupta. VKC is a seasonal recurrent conjunctival inflammation presenting with just irritating allergic eye disease to a vision-threatening condition. It is twice commonly found in young boys compared to the girls. It presents with symptoms like eye itching, foreign body sensation and burning sensation, and signs like Tranta spot, limbal hypertrophy of papillae, and superficial keratitis. The pathogenesis can be summarized in the following flow charts, where we have been conventionally targeting the specific sites, like with the steroids we are targeting the APCs and the peptide produced by it, the mast cell stabilizers, the antihistaminics, and the newer one are the immunomodulators, which particularly target the T helper 2 cells and IgE in this process. So we decided to evaluate the side effect and efficacy of topical interferon alpha 2B and tacrolimus in the treatment of vernal keratoconjunctivitis. In this method, we identified the study group with the patient of vernal keratoconjunctivitis, explained the nature and obtained an informed consent, randomly allocated the patients in two groups with the interferon alpha 2B and tacrolimus, and followed up the patient at 2 weeks, 1 month, 2 months and 6 months based on the clinical scoring system as follows, where the total subjective symptom score was given from 0 to +3 and the total objective science score was also given from 0 to +3 in following manner. In results, we found that 80 patients of VKC were randomized into two groups with average age of 7 to 11 years and 3:1 male-female ratio. The total subjective symptom score with group A, that is tacrolimus, was at baseline was 6.87, and it further increased with the treatment and was significant at the end of the 4 weeks, which was highly significant at the end of 8 weeks. Similarly, we could find that the symptom score was significant with interferon also at the end of 4 weeks and highly significant at end of the 8 weeks. Side effects like burning sensation was seen with the tacrolimus, but such side effect was not seen with interferon alpha. The objective sign score also showed a gradual improvement with end of the 4 weeks with 2.88 and at the end of the 8 weeks to 0.67 with tacrolimus, as well as with interferon. It was significant at the end of 4 weeks and highly significant at the end of 8 weeks. The graph also showed that there was progressively betterment in the symptoms, as well as even after stopping the drug at 6 weeks. It slightly showed an remission at the end of the 6 months in both the groups. Treatment of VKC has been challenging. Mainly the mast cell stabilizers, antihistaminics and the corticosteroids has been the line of treatment. However, none of these agents abolish all the symptoms and side effects. Interferon alpha-2b and tacrolimus were used in such study to keeping the recurrence rate and the side effect of the conventional treatment. Many studies have been carried out where the refractive patients were taken into consideration, but here we tried to break this stereotype and started immunomodulator as the first line treatment. As we have seen that improvement was seen as early as 2 weeks, but it was significant at the end of the 4 weeks and highly significant at the end of the 8 weeks with both the drugs. Though at the 6 month there was increase in both TOS and TSS, but it remained significantly below the baseline. Side effect like burning sensation was seen with tacrolimus. Concluding that the significant improvement in TOS and TSS was seen with tacrolimus as well as interferon alpha-2b, but interferon alpha-2b statistically better improvement and better tolerability with no side effects. Concluding that both are safe and effective but may show a remission in long-term follow-up. Limitations of my study was there should have been a systemic tapering with a long-term study to be undertaken. Thank you.
Check. You have told the results of both the drugs separately.
Yes,
have
sir.
you compared them actually?
The intra-group comparison
Yes.
was done, but there was no statistically better improvement in tacrolimus or interferon.
No, but that you have not presented in your results.
No,
that
it was not in the
not
slide.
presented.
Yes, sir.
You have presented individually.
Yes, sir.
And you came to a conclusion that tacrolimus is better.
Interferon is better in only the side effect profile wise, but as of the result, both are equally potent. Int alpha from the Ajanta pharmaceutical injection we get. We don't get the drops. We need to prepare it from the injection. Or reliferon is also available.
My question is, what was your preference of interferon to cyclosporine? And number two, you said that the symptoms improved.
Yes, sir.
But you didn't speak about the signs of regression of papillary hypertrophy, pseudogerontoxin,
Yes, sir.
limbus.
Answering your the first question, sir, after seeing the results with my study, cyclosporine always comes with a side effect of a burning sensation and adaptation to patient. Interferon alpha-2b didn't show that things. And the second question was that I have studied the total subjective signs score, which objective signs score, which showed improvement in the papillary hypertrophy also and the Tranta spot also, sir.
Thank you. Next, we have Dr. Nishi Prasad. Are you here? And Dr. Anupam Singh. Yeah, after Nishi. Take up this.
Good afternoon, everyone. My topic is fetal hemoglobin and development of ROP in preterm babies. So we know incidence of ROP in India is very high, as far as 38% to 51%, and there are so many papers related to risk factors. Only few papers are there which is related to the protective factor. One of such factor is fetal hemoglobin. And in literature, only 2 papers are there showing correlation between fetal hemoglobin, blood transfusion and ROP. Hence, we chose this title. The aim of our study was to correlate between fetal hemoglobin concentration, blood transfusion and ROP in preterm infants. This was a hospital-based prospective observational study run for a period of 1 year at GMC Bhopal, and all preterm infants less than 36 weeks and less than 2 kg birth weight were included in this study. All preterm neonates were divided into ROP and no ROP group,
The infants who had ROP were again divided into those who progressed, those who regressed after treatment, and without treatment. So the concentration of fetal hemoglobin was found to be very low in ROP group compared to those of no ROP group. Also, there was inverse relation between the staging and fetal hemoglobin. Higher the staging, lower was the fetal hemoglobin levels. The infants who had shown progression had lower fetal hemoglobin levels, and those who regressed has higher fetal hemoglobin levels. Blood transfusion and volume of blood transfusion was found to be significantly associated with the development of ROP. So area under the curve of ROC curve was 0.976 with very high sensitivity and specificity for fetal hemoglobin. So here we can see the concentration of fetal hemoglobin was less in ROP, and there was a demarcation at around 56% of fetal hemoglobin between ROP and non-ROP group with very high sensitivity and specificity. So fetal hemoglobin was significantly lower in the ROP group than in non-ROP group. Higher the concentration, lower was the staging. The probability of developing ROP and its progression was less in infants with fetal hemoglobin more than 60%. So this is the first Indian study and third worldwide study correlating fetal hemoglobin, blood transfusion, and ROP, and concluding that replacing fetal hemoglobin by adult hemoglobin during blood transfusion may promote development of ROP. Concluding, replacing fetal hemoglobin by adult hemoglobin during blood transfusion may promote development of ROP. Conversely, maintaining higher fetal hemoglobin levels may be protective for developing ROP. So our recommendation is that adult blood transfusion should be given with caution in susceptible preterm babies as it dilutes fetal hemoglobin level, thereby increasing the risk of development of ROP. So this BORN study, a multicentric randomized trial, is going on, suggesting the cord blood red blood cells transfusions to reduce the severity of ROP in extremely low gestational age neonates. Thank you.
Any question?
Yeah, you said there is an inverse relationship. So 67 cases regressed
Yes, sir.
and 10 progressed.
Yes.
What about the ratio of the fetal hemoglobin versus in case where there is no ROP in preterm babies?
Where there was no ROP, the level of fetal hemoglobin was high, sir.
But that was not projected in the result, right?
No, sir. The next table that I had shown is, sir, only ROP babies. The first table was of ROP and no ROP. Second table was of only ROP babies who progressed and who showed regression after treatment and spontaneous regression. So total 110 ROP babies from 410.
It's a very good study, but you have not touched the other aspects that would have had effect on the staging of RS, like septicemia, oxygen levels, and hemoglobin levels. That aspect should have been taken in your study.
So
Because it's not the staging, you said that it's correlation of HB hemoglobin, fetal hemoglobin to severity and degree of ROP. But to us, other factors are more important. So why did you not mention about whether these kids had any septicemia and what was the duration and amount of oxygen therapy received?
Yes, sir. Sir, I have shown in one table where there was blood transfusion, other factors also, like oxygen supplementation more than 1 week, septicemia, respiratory distress syndrome was associated with the development of ROP.
Any more questions, or should we go to the next?
I just wanted to know that there is something known as cord blood milking also, which is going on just to promote this. So this is something which can be done at every primary level care to improve the outcomes.
Yes.
So your study is excellent, and I think this should also be a step forward to make it all
Yes.
over universal in India. Thank
Yes,
you.
Thank you.
Dr. Anupam, and after Dr. Anupam is Dr. Jayadev Nanda.
Good afternoon, everyone. Today I am going to present my thesis topic, that is a comparison of the optical coherence angiography, optical coherence tomography angiography, and the fundus coherence angiography in the patient with a diabetic no financial interest in this presentation. As we all know that the diabetes is a growing worldwide epidemic, and in India, the prevalence of the diabetic macular edema in the people with diabetes is reported to be 8.9%. Although the fundus fluorescein angiography has been used as a gold standard, and it is used to assess the leakage in the vascular bed, particularly in the macular edema patients, but it cannot be used repeatedly due to the toxic nature of a dye and some side effects. Whereas the SS-OCT-A, which is a newer technique which can acquire the images of the retinal vasculature without the need of any toxic or invasive procedure. The aim of my study was to assess the effectivity of the OCT-A when compared to FFA to detect the various structural features in the patient with the diabetic maculopathy. The hypothesis was that the optical coherence tomography angiography is a comparable substitute to FFA analysis of the retinal vascular pathology in the diabetic maculopathy patients. The objectives of the study were to compare the OCT-A with the FFA to evaluate the following structural features, which are FAZ diameter, FAZ distortion, number of microaneurysm, number of neovascularizations, number of CNP areas, and number of enemas. The study was conducted at the outpatient department of the Regional Institute of Ophthalmology, Sitapur, with a duration of 2 years. It was a cross-sectional agreement study of 2 diagnostic tests with the sample size of 102 eyes. The patient inclusion criteria, the patient which were above the age of 18 years with a diabetic maculopathy was taken in the study. For the image acquisition, for the OCT-A, we use the Topcon DRI OCT1 Atlantis substitute OCT, whereas for the FFA, we use Visicam 500 machine, which is from the Carl Zeiss Optics. And to quantify the area of the consideration in the FFA, we use Java-based images software. These are the subsequent images which are taken for the study. Now coming to the result, the best corrected visual acuity in the right eye at presentation in the patients was 0.84 with a standard deviation of 0.82, whereas in the left eye it was 0.91 with a standard deviation of 0.91. When compared on FFA and OCT-A, there was 0.85% difference in the horizontal diameter measurement, whereas there was a 2.16% difference in the area measurement. When this data we applied the Pearson correlation coefficient, we found that there is very strong to perfect agreement in the horizontal diameter area, horizontal diameter and the area measurements. For the comparison of number of microaneurysm, we found that the FFA was better. And for the neovasculature elsewhere, we found that the agreement was observed in the 96 eyes with a K value of 0.902, which shows almost perfect agreement. For the CNP areas, we found that the agreement was observed in the 93 eyes with a K value of the 0.84, which shows almost perfect agreement. And for the enemas, we found that there was agreement in the 88 eyes, which showed the substantial agreement. Coming to the discussion, we found that the horizontal FAZ diameter and FAJ area shows very strong correlation when compared between the FFA and OCT-A. For CNPs, the agreement of the FFA and OCT-A was found to be almost perfect. And to assess the burden of the exudation, one need to study about leakage, which can be only studied on FFA, and it is exclusive to it. The limitations of my study were low sample size, and our OCT imaging was confined to the posterior pole, so we were not able to assess the peripheral vascular changes. To conclude, the SS-OCT is a reliable, non-invasive, convenient and reproducible technique when compared to FFA, and the foveal avascular zone details study on OCT-A shows very strong agreement with FFA, where the horizontal diameter shows much stronger agreement. These are my references. Thank you.
Any questions?
Sir, OCT-A, if leakage is there, sir, it will be shown as the artifact, sir, and we will not able to see the vasculature and assess it, sir.
And your title is on maculopathy, but why do you want to look for CNP areas and peripheral neovascularization in this study?
Sir, actually, in this study, we used the cube of the 6 mm in the 6 mm and confined to macula only, sir. Sir, although the CNPs are in the starting, it has seen at the periphery, but in some cases, we found that they are coming to the macula also, sir. So we included that in the study, sir.
No, that is macular ischemia.
Yes, sir.
The peripheral capillary non-perfusion area, why do you want to analyze in this study, I'm asking? Because it's not in the purview of this particular study, right? It's basically about maculopathy.
Yes, sir.
Okay, thank you. Thank you, Dr. Anupam. Now, Dr. Jayadev Nanda. And after Jayadev, we have Hirika Gosalia. Dr. Hirika, are you here?
Good afternoon, everyone. I'm going to present my thesis on having title Comparison of Ganglion Cell Layer Thickness on Optical Coherence Tomography and Waveforms on Pattern Electroretinography among glaucoma suspects and healthy control. No financial interest to disclose. As you all know, glaucoma is characterized by chronic progressive optic neuropathy resulting in characteristic visual field loss And we all know that prevalence of the glaucoma worldwide is 3.54% and 2.3 to 4.7% in India. And by 2040, it will be around 112 million cases. And standard optometer perimetry is being the gold standard for the glaucoma detection, but it requires at least 25% of RGC loss to be detected. So the pre-perimetry glaucoma cases can be assessed structurally by OCT and functionally by pattern ERG. So rationality behind our study is that these two tests are non-invasive and objective method, and it will help in early assessment of developing glaucoma. So novelty of our study is that to our best knowledge, no such study has been taken ganglion cell layer thickness alone and compared it at different locations at 3 mm, 3.45 mm and 6 mm in macular region, and very few studies have been reported taking PARG parameters comparing between glaucoma suspect and healthy control. So we expected that there will be decrease in GCL thickness and increase in implicit time and decrease in amplitude of pattern ERG waveforms, and which can be utilized to prevent the progression of the disease earlier. So our aim was to evaluate the difference between of GCL and on OCT and waveforms on pattern ERG among these two groups. And so for that, our objective was to measure the thickness of GCL on OCT and implicit time and amplitude of P50 and N95 waves on pattern ERG. So it was a cross-sectional observational study done at AIOS Patna. We included 40 to 60 years of patient having suspicious optic disc characterized as vertical cup disc ratio of more than equal to 0.5, diffuse or focal or narrowing or sloping of the disc rim, and it is hemorrhage or asymmetric of appearance of the disc rim between the fellow eyes of more than 0.2, and the subjects having the apparently normal finding as control group. We excluded the known cases of glaucoma and any primary or secondary angle closure, high IOP of more than 21 diopter, refractive error of more than 4 diopter, and subjects having any visual field defect, any coexisting retinal disease and medial opacity. And we calculated the sample size according to this assumption, and we concluded at 25 in each group, but we have taken 50 in each group, total 100 eyes. And this is the flow chart showing the patient coming to our OPD. We have excluded the high IOP angle closure cases and the patient with a visual field defect, and finally performed the test. These pictures are showing of our patients, and this is the only GCL layer we have taken, and this picture showing the pattern ERG of our machine and the patient, and this is the waveform. And statistic analysis we have done on Jamovi software version, and we have applied the students independent t-test for the to find out the difference, and p-value of less than 0.05 was taken into consideration. And we found that OCT at 3.45 mm circle and at 6 mm circle, there was significant difference between these two groups. And for the P50 amplitude and implicit time, both significant for between these two groups. And for the N95, we found only implicit time being the significant, but not the amplitude of the N95. On different literature study that there were some studies reporting they have found the similar findings, but they have compared the GC IPL thickness into measurement and did not mention regarding their location. And this difference of GCL thickness was, we found that there are more in difference in 6 mm circle than at 3.45 mm circle. For the P50, Gion et al. Supported the same increase in implicit time for P50, but Zhang et al. Supported decrease in amplitude time, but Wenkel et al. No significant change was observed. For N95 time, implicit time was similar to Zhang et al., but we didn't find any significant difference in amplitude of N95, but other studies have found that. And limitation of our study was small sample size, hospital-based study, and corneal jet electro to conclude on the basis of morphology of the optic discs and structural functional evaluation of retinal neurons can be done. And thickness analysis of GCL alone can also help in change in glaucoma suspect, and PRG findings can be of helpful for in glaucoma suspects. Thank you. Pattern ERG. No, ma'am, we didn't have done all those things.
How did you screen patients? How did you suspect them, say somebody having a shallow chamber, exfoliation, steroid user, or family history? What was the criteria of screening patients who would undergo an OCT?
Sir, actually the patients who are having, we have given them a comprehensive ophthalmic evaluation. After gonioscopy, we have excluded. After high IOP, they have excluded. We have excluded all those patients.
No, my question is,
Yes.
say you have 100 patients in
Yes, sir.
your OPD.
Yes.
Whom do you suspect that this patient needs a ganglion cell evaluation or this electrophysiological test?
As we have discussed, we have taken patients, subjects with patients suspicious for subjects having the optic days suspicious for glaucoma. Like we have discussed, vertical Koptis ratio more than equal to 0.5 or any asymmetric Koptis ratio.
Okay.
Sir, jet electrode, ERG jet electrode.
Thank you. Dr. Hirika, are you here? Dr. Pragya? Yeah.
Hirika, not Pragya.
No, it's Hirika, not this one.
Can I do it? Hirika, not Pragya.
This is the wrong presentation. Can
This
you
is
put
the
up
next one. Can we have the previous one? Hirika Gosalia.
Patients with metamorphopsia after rhegmatogenous retinal detachment surgery. So as we all know, metamorphopsia is a prevalent symptom in 2/3 patients post-operatively after macula-off surgery, and it impairs the fusion and compromises the binocular single vision in patients. And there's a high risk of binocular diplopia, asthenopia, or retinal rivalry unless one of the images is suppressed. So the aim was to determine these structural abnormalities in patients with post-operative metamorphopsia who's undergone a RRD surgery, a macula off. And we did this using the OCT and the FAF, and we determined the relationship between these and the post-operative outcomes. So the study design was a prospective study done in Arvindai Hospital for 18 months in 30 patients. In patients complaining post-op 3 months metamorphopsia. So my inclusion criteria was patients more than 18 years of age, patients post rhegmatogenous retinal detachment with visual acuity better than 6/18, patients with no media haziness, patients with successful retinal reattachment following surgery, and macula off RRD. So patient consent was taken, medical history was taken, imaging was done with SD, OCT and fundus autofluorescence. The diagnosis was based on the laterality, total or subtotal macula of PVR grading, break, lens status. And the operative procedure was of the pars plana vitrectomy with tamponade under subtenance anesthesia. So post-operatively 3 months, we took the best corrected visual acuity, contrast sensitivity, Amsler, slit examination, OCT and FAF. So the type of tamponade used, 80% was silicone oil and left eye was 53%. In duration of RRD was from 2 days to that of 90 days. And we saw FAF finding of retinal vessel displacement in which the white arrows, which you can see, show hypofluorescent imprints from the previous vessel position. OCT findings like cystoid macular edema, retinal folds, lamellar macular hole, inner segment, outer segment disruption were noted. So in OCT findings, the maximum patients suffered from that of inner segment, outer segment disruption followed by ERM. And that of fundus autofluorescence, we found maximum patients having retinal vessel displacement. When we compared that with the type of surgery with respect to the tamponade used, retinal vessel imprinting was noted in many patients of gas tamponade, which was showing significance. And this statistical significance was noted with a p-value of 0.0016 for groups of gas tamponade and silicone oil agent for vitrectomy. So we found this statistical significant association between the retinal vessel displacement, which revealed that patients undergoing vitrectomy with gas tamponade experienced more post-operative metamorphopsia. 4 patients in our study had no macular changes. This could be because of glial proliferation on the photoreceptor layer causing traction on the macula, which was not seen in the imaging. And duration of RRD was not found as a significant risk factor for our study because maximum cases were fresh. And other studies that were done also showed similar results. Though they all had different outcomes, but there were few studies which also noted retinal displacement. So I would like to conclude by saying that maybe retinal vessels may move downwards post-operatively and hence could be a main cause for post-operative metamorphopsia. And fundus autofluorescence is a valuable tool. And our study revealed post-operative metamorphopsia is not affected by duration of RRD or post-operative BCVA. Long-term FAF study with bigger sample size was a limitation. Thank you.
We have a lot of literature saying this, right? This is not the new study.
But sir, in India, there's only one or two more studies.
No,
and
but already done, right?
Yes,
So,
sir, but their outcomes are varied. They say that we need more prospective studies.
yes.
The outcomes are varied in every study, so there's not been a definite outcome in any one study.
Second thing is it's very common with gas than with silicon oil.
Yes, sir.
But your sample, you are concluding the same.
Yes.
But your sample of silicon oil is much more
Much
than
more, so
you
yeah.
had only 6 Ks.
Yes, sir.
So with that 6 Ks coming to this conclusion.
No, we are not. We have said that as a limitation that gas terminal has shown in other studies and our study, but we are not very, because the sample size is very less, we are not conclusive about it.
And third thing is, how can you assess the displacement of the vessel in a macula of RD? Because they have done the mapping prior to the detachment surgery and post.
Yes, sir. We have done only post 3 months. So mainly when you see the black shadow and the new displacement, black shadow denotes that of the previous placement of the same vessel before the surgery, and this is a new displacement that has occurred after the surgery. So that has been noted in
And
many
what was the duration between the surgery and the, is there any
3
correlation?
months between the?
No, what was the mean, time of intervention in all these cases?
So it was ranging from 2 days to 90 days, but we didn't find any significance for the duration of RRD which could have related with these outcomes.
But that's a huge range. What is the mean and the standard deviation?
Around 50, more with the more than 20, 30 days. So it was around 32, I'm not sure of the exact value, but it was around 43 point something.
Standard deviation?
I can't remember it right now.
The only tool used by you was Emsler grid, but you didn't mention what were the findings on the Emsler grid.
No, sir. So mainly we looked at patients which came with post-operative metamorphopsia. Quality of the vision was what we looked at. Then we measured the Amslers, but only in patients with better than 6/18 vision. So mainly if patients are commenting on their quality of vision, we did the Amslers, but we have not, I have not shown it, but yes, we have found some distortions in the Amslers grid.
Patients following RD surgery.
Yes, sir.
People with 660 vision are much more happier than the people with
Yes, sir. That's why that was our inclusion criteria, to just look at the patients with better outcomes.
Thank you, Dr. Harika. I call upon Dr. Pragya Ahuja, and next is Dr. Shalin Shah.
Good morning, respected judges and fellow colleagues. I'll be presenting my thesis, a study on candidate gene polymorphism in patients of diabetic retinopathy in Indian population. I have no financial interest or conflict of interest, financial disclosure, conflict of interest. It has been seen that microvascular complications of diabetes are generally due to increased accumulation of advanced glycation end products, which are detected by the receptor for advanced glycation end product. These receptors are present in part of the MHC immunoglobulin family present on chromosome 6. Identifying genes that may be responsible for the severity of the disease affecting the RAGE gene will not only better our understanding of the pathogenesis of diabetic retinopathy, but also develop new approaches. So our aim was to detect 374 thymine replaced by adenine and 429 thymine replaced by cytosine single nucleotide polymorphism in RAGE gene in healthy controls diabetic patients with and without retinopathy. These were the two polymorphisms, 429 T by C, 374 T by A polymorphisms that were considered in the promoter region of the RAGE gene sequence. It was a prospective case control study conducted among 90 subjects, 30 healthy controls, 30 diabetics with retinopathy, 30 without, and it was done at Retina Clinic at AMU. 10 ml blood sample was taken following WHO septic precautions. 7 ml was kept for biochemical investigations. 3 ml was taken up for genetic analysis. The samples were centrifuged and kept at -80 degrees till they were taken out for analysis. The spin column method DNA isolation kit was used and till the subjects were till the samples were subjected to PCR. All samples with purity less than 1.7 to 1.9 of DNA were rejected from the study. The DNAs were amplified with PCR and was digested by a specific restriction endonuclease ALU1 and TSP509I for respective incubation hours. These digested DNA samples were then subjected to restriction fragment length polymorphism, of which were imaged using the BioRad software, and these were the bands that we obtained during our study. The analysis of these bands was done based on a pioneer study by Barry Hudson et al. In 2000, early 1900s, where he had explained which polymorphism will lead to what length of the base pair. These were the results of my study. 374 T by A polymorphism was significantly associated with diabetic retinopathy. A allele was significantly associated with the causation of diabetic retinopathy. All this was done assuming the dominant model of inheritance. No such inheritance pattern was noted in the codominant model. Second, 429 thymine replaced by cytosine was not found to be associated with diabetic retinopathy. When compared to healthy controls, 374 T by A polymorphism was present significantly in both diabetics with and without retinopathy. However, no significant association was seen when the similar comparison was made between patients with diabetes with retinopathy and without. However, the odds of this polymorphism occurring in patients with retinopathy was more than those without. Duration of diabetes was seen to be a significant factor for the development of diabetic retinopathy. And among the lipid profile, low HDL levels, fasting and postprandial blood sugar, serum creatinine was significantly associated with the patients of diabetic retinopathy. In the hemogram, RBC count and MCHC was significantly seen more with patients with retinopathy. However, we think that this was an incidental finding as we could not corroborate with our previous results. What is the relevance of this study? There is no uniform data available for the North Indian population, and it was a pilot study. The polymorphism 374 T by is associated, 429 T by C is not associated, and this will encourage collaborative efforts on the national and international level for at-risk population and encourage further genome-wide studies. My limitations were we did not assess the downstream expression of this polymorphism with serum RAGE levels. Other polymorphisms also influence the pathogenesis, which we have restricted ourselves to RAGE gene, and haplotype analysis will give us a better picture. Thank you. Thank you.
Nice presentation. Is this your PG thesis?
Yes, ma'am.
Okay.
Ma'am, we did it with the biotech department. Mr. Amit Mukherjee, sir, he's pursuing PhD in biotechnology. He's working on nephropathy. I worked on retinopathy.
Okay.
Yes.
Any questions? Okay. So next we call upon Dr. Shalin Shah. After Shalin is Parvati Narayanan. And after Parvati is Neelima Matthew.
So good afternoon everyone. I am presenting about alterations in retrobulbar hemodynamics after orbital decompression surgery in inactive moderate to severe thyroid eye disease. So disclaimer, this article has already been published in Eye last year. So following the Rundle's curve, we know that active thyroid eye disease, there is inflammation, so blood flow in the orbit will increase, and in the inactive disease, inflammation goes down, blood flow decreases. So we measured the blood flow in two arteries, central retinal and ophthalmic artery. The Doppler placements are shown. We calculated the peak systolic and end diastolic velocity and the resistivity index as shown in the formula. The literature does not have any information about effect of decompression surgery on the orbital perfusion. So we studied that in this, following this methodology. We had 18 to 65-year-old moderate to severe inactive thyroid eye disease patients. We excluded all smokers and other orbital diseases which could have influenced the blood flow. We had 24 orbits enrolled who underwent lateral decompression surgery. We had another 24 orbits of moderate to severe thyroid eye disease who did not undergo any surgical intervention as a comparative group. And we had a third group of 18 healthy orbits with refractive errors. So these are the demography parameters. All the three groups were age and gender matched. So these are our post-operative results where we can see the proptosis is reduced, the periorbital puffiness and retraction are reduced. So our results, proptosis and IOP reduced significantly. The velocities in central retinal artery and ophthalmic artery showed significant increase, and the resistivity index, that is resistance to blood flow in both the arteries, reduced following orbital decompression surgery. And here we have the pre-op and post-op images where we can see these are the Doppler waveforms, and in each case we can see that there is significant increase in the blood flow velocity after decompression surgery. The second group, where we just observed the TED orbits, they had no change in parameters, which shows the natural course of disease, that an ischemic orbit will remain an ischemic orbit. And the C group, which was the healthy controls, all of the healthy controls had better velocities than the thyroid eye disease orbits. And the Doppler parameters correlated with the duration of thyroid disorder. We also did an area under curve analysis, and we found that the healthy orbits could be distinguished from the thyroid diseased orbits, and ophthalmic artery peak systolic velocity had the highest area of almost 0.98, and we established cutoffs. Similarly, we could establish cutoffs for mild and moderate to severe thyroid eye disease. That is, severity could be graded based on Doppler values. So why is this study important? Orbital decompression surgery currently we use for inactive disease, we use it usually for cosmetic purposes, but it also improves the blood flow. So when there is ischemia in the orbit, which could affect the optic nerve functions, like it is documented in normal tension glaucoma, PSEG, POAG, it could help prevent dysthyroid optic neuropathy, as well as it would prevent the apical compression and apical crowding. This study establishes cutoffs for distinguishing a thyroid orbit from a healthy orbit and to distinguish the severity of disease. This could prove to be an adjunct to the currently available clinical activity scoring and the visa scoring for thyroid eye disease. So this would provide another quantitative indicator as compared to the qualitative analysis done in clinics for thyroid eye disease. So these are the sites of placement of the Doppler gates in our study. And the sites of vascular resistance would be intraocular in the fibrous muscles and direct compression of the ophthalmic artery at the orbital apex. So intraocular, we can't manipulate the fibrous muscles, we can't manipulate. We can relieve the compression of the vessels at the apex through a decompression surgery and thus improve the perfusion of the orbit. Thank you.
Hello? And which type of decompression you do it? A single wall, a double wall, or?
Sir, it was lateral decompression, deep lateral wall decompression, single wall.
It is an extended lateral wall decompression?
Sir,
because you decompression, so when you do a parameter should be fixed.
Yes.
I will do extended lateral decompression in all the cases, then you have to.
Sir, it was the same surgery. We went through an extended upper lid crease approach. We did a deep lateral wall decompression involving the sphenoid trigon area only. We did not go to the inferior wall or the medial wall, no balance decompression.
Only lateral wall.
Only lateral wall, yes, sir.
Yeah, it is in a sphenoidal dorsum.
Sorry, sir.
The xeno of the
yes, sir.
sphenoid.
In the greater wing of sphenoid, trigon area of the sphenoid, we decompressed.
That is a sphenoidal dorsum.
Not the basin. You mentioned only the door chamber, right?
Yes.
Trigon area.
Yes, only the trigon area we decompressed.
Okay. And how the blood flow is measured in the apex?
Sorry, sir.
Blood flow of the orbital apex, how will you measure?
Sir, we used a color Doppler imaging
The
as
imaging
I had
from
shown.
where? How the probe is
Yes, sir.
the deeper
So,
side?
over a closed eyelid, we positioned the probe, and central retinal artery was measured around 3 to 10 mm from the posterior sclera, and the ophthalmic artery was imaged 30 to 40 millimeters from the posterior sclera, that is at the orbital apex, where it was just crossing the optic nerve. So, sir, I did the Dopplers myself. So, we read the literature and then we did the Dopplers, and the surgery was done by my guide.
Lots of structure is there, because the eyeball is there, in the deeper structure, in the orbital apex.
Yes, sir. The color Doppler gives us
I know.
the orange and the blue colors. So superior ophthalmic vein is clearly distinguished, and we can easily identify the ophthalmic artery, and it just crosses the optic nerve, just superior to the optic nerve. So we can determine it.
Lots of index is there, flow index.
Yes, sir. So we use resistivity index because previous studies in glaucoma, they have shown that resistivity index is the most reliable and the replicable of all the. There is pulsatility index, there are some other mean indices and the individual velocities. And we excluded posterior ciliary arteries because they are numerous and they are extremely small. So the placement of the Doppler gate is very difficult, and the velocities of posterior ciliary arteries are very unreliable unless they are done by an experienced radiologist. And even studies.
Which state of the thyroid disease you?
So these were all inactive.
Suppose in Randall's curve, which state of the disease you work there?
So these patients were inactive for the past 6 months before we enrolled them.
How many days is inactive for?
So at least 6 months.
6 months.
So they were inactive for 6 months. Their mean duration of disease was, in most of the cases, it was more than 5 years, more than 60 months.
What about the lid retraction of that patient?
Yes, sir. A lot of patients had lid retraction.
But retraction is not going there. We have to do lots of pre-surgery.
Sir, decompression, then squint, and then lid surgeries. Sir, we stopped at decompression, then the patient was referred to the strabismus unit.
When was the Doppler done?
Pre-op and post-op after how many days? Ma'am, 3 months. Because
Studies have shown that up to 6 weeks there could be residual change, inflammation in the orbit which could influence. So we waited up to 3 months, and we did not give any steroids. We gave serratiopeptidase instead, because steroids would have influenced the inflammation in the orbit, and it could have influenced the parameters, Doppler parameters as well. So we removed those confounding factors, and even smokers, diabetics, hypertensives, anyone who could develop vasculopathies, they were excluded from the study.
Okay. So next we call upon Dr. Parvati Narayanan, and after Parvati, Neelima Matthew.
Good afternoon. I will be speaking on the topic of the evaluation of the objective factors affecting the visual outcome of ONSF surgery in patient with IH, a study in COVID era. IH is a clinical syndrome of unknown etiology in which intracranial pressure is raised in the absence of vascular or space-occupying lesion. It is a disease linked with obesity. Its importance lies in the fact that it can lead to irreversible vision loss. The mainstays of the treatment remain weight loss and medical management. Patients who are refractory to medical treatment, surgical intervention can be required. The options include ONSF surgery or CSF diversion procedure. So why we did this study? The improvement of the stabilization in the visual outcome in terms of both visual acuity and the visual field after ONSF surgery. Those who diagnosed with IH is documented by various studies. Few studies evaluated the demographic factors and patient subjective factors to predict the visual outcome after ONSF. The paucity of the literature still on this is objective factors are knuckle thickness, optic nerve sheath diameter to predict the outcome. So our primary objective was to evaluate the objective factors, both the functional and structural parameters affecting the visual outcome over the period of 3 months, if possible up to 6 months in patients diagnosed with IH planning to undergo ONSF. So it was an ambidextrous observational single center study. Sample size was 12. The time period is for this is 3 years, and the place of study, Department of Ophthalmology, AIIMS, New Delhi. So after satisfying this is modified Dandy criteria, the patients with the IH came into this is neuro-ophthalmology OPD, and after meeting this is inclusion criteria, underwent a comprehensive history taking like associative factors of IH, age at onset of IH, time to ONSF, general examination, BMI, weight, ophthalmic examination, BCA using Snellen's chart, anterior segment examination, clinical picture of the fundus to document the stage of papilledema, and other investigation, opening pressure of CSF that is already done at the Department of Neurology, OCT to measure this is RNFL thickness and GCC IPL thickness, BER, USG for optic nerve sheath diameter. And after all comprehensive examination, patient posted for this is surgery. All investigations were repeated on post-op day 1, 2, 6, 12 and 24 weeks if possible. So coming to the results, the study recruited the 12 eyes underwent ONSF surgery. Out of 12, 7 eyes evaluated the prospectively and remaining 5 eyes retrospectively owing to COVID-19 pandemic. Mean age of the study group was 34.5, mean weight was 66.5, mean BMI was 25.76, mean time to ONSF from the time of the diminution of the vision was 108 days. Coming to this, our primary objective, that is changes in the functional and structural parameters over the 6 months, and this is either eye. Here is the line graph showing this is changes in the best corrected visual acuity over the 6 months. There is a significant improvement in the best corrected visual acuity in the operated eye and in the fellow eye with P is equal to 0.045 at 6 weeks and 12 weeks in the operated eye, and P is equal to 0.045 at 24 weeks in the fellow eye. Coming to the amplitude of the VR, there was an improvement in this is either eye with P is equal to 0.04, that is significant change in the operated eye. Going to the latency of the P100, there was a significant improvement. This is both eye with the P is equal to 0.027 and P is equal to 0.046 at 6 and 12 weeks in the operated eye, and P is equal to 0.046 at 24 weeks in the fellow eye. Coming to the OCT, the RNFL thickness shows significant reduction with the P is equal to 0.04 at 6 and 12 weeks in the operated eye with P is equal to 0.04 at 24 weeks in this is fellow eye. And the GCL IPL thickness got stabilized even though there is no significant change was noticed, and this is post-op follow-up period. Going to the optic nerve shear diameter, and this is axial section that showed significant reduction in the immediate post-op period with P is equal to 0.02 in the operated eye at 2 weeks. We have also done correlation with preoperative functional and structural parameters with the final visual acuity. There was a significant correlation found with the pre-op visual acuity with the final visual acuity with the P is equal to 0.04. There is also strong correlation found with the time to the ONSF with the final visual acuity with the R is equal to plus 0.83 in the operated eye and plus 0.81 in the fellow eye. Preoperative optic nerve shear diameter on axial section also showed strong correlation with final visual acuity. So coming to the conclusion, ONSF surgery helps in the either improvement or stabilization in the visual acuity in either eye. Improvement in the objective parameters indisputably obviate the need of bilateral ONSF in all cases. Improvement in the final BCVA primarily depend upon preoperative BCVA, time to ONSF, and preoperative ONST. The limitation of my study was sample size was less and it did not represent general population, and it was an ambidextrous study. Structural parameters couldn't able to assess in all patients. Thank you.
No, your title says it's about the COVID era. So is there any difference in the outcome in pre-COVID, COVID, post-COVID?
No, sir.
Why that was added to COVID era? Or all these patients are COVID positive or something like that?
No.
Okay.
No, actually recently no.
You did the thesis during COVID era?
Yes.
Okay, that is the
So
reason
the
COVID
sample
was...
size was less, and we couldn't get enough sample size. And 7 patients we analyzed prospectively, and 5 patients we were analyzed retrospectively.
So COVID and COVID era has got nothing to do with this outcome.
What was the opening pressure that you have taken into consideration? How much was the opening
pressure? No,
pressure?
ma'am, opening pressure per se, it's not a criteria for that.
No, I know you have mentioned that you have measured the opening pressure in every patient.
Yes.
So what was the baseline opening pressure you have considered for the fenestration surgery?
Ma'am, no, we are not considering that opening pressure per se as a consider for this surgery. The opening pressure we have done to diagnose this is IAH. That is
normally when it is below 25 we
yes,
go conservative,
25
right?
of the
Above
water.
only we
yes,
go for
we
surgery. Next is Nilima Matthew, and this is the last presentation.
Good afternoon. The thesis topic is Functional Vision Assessment in Children with Global Developmental Delay Coming to a Tertiary Care Center. So vision impairment is known to occur in children with multiple disabilities. Accurate assessment of vision in this group is difficult as they may be nonverbal with intellectual impairment or motor disability, and their comprehension is limited. Hence, instead of doing only a conventional vision assessment, we must also perform a FVA or functional vision assessment. Functional vision is defined as vision that can be used to perform a task or tasks requiring vision. That is how a person uses vision in his daily life. The goal is to determine what and how the child sees and what can be done to best facilitate learning, and then how to help in the intervention programs. So these are the basic differences between conventional and functional vision assessment. So that will be each eye will be separately measured in visual conventional assessment, whereas in functional the person as a whole, and they also consider non-visual factors in FVA. Primary aim is to assess functional vision in children with global developmental delay. Secondary is to correlate the functional vision with severity of disability and conventional vision. Children with GDD from 6 months to 5 years were included in the study. Children with primary ocular disorders like cataract, glaucoma, vision-threatening ROP, and retinal dystrophies were excluded. Cross-sectional and observational study. And in methodology, detailed birth and perinatal history of this DDD children were taken, and ophthalmic evaluation was done in 2 stages, conventional and functional. During the first visit, visual acuity was assessed using both qualitative and quantitative tests, and the second visit was to assess functional vision. So functional vision was measured in following ways, like visual attention was noted, vision for orientation and mobility, vision for communication, and cognitive vision. So alertness, curiosity, saccades, pursuits, all these were noted in the visual attention. Visual sphere, quality, robustness, clutter, and object permanence for the orientation and mobility part. For communication, facial recognition, and joint attention were noted. Cognitive vision, following tests were done. So this is a mirror gazing child. can be used to assess the visual alertness, and this second one is for visual sphere. Here the visual field of this child is seen. The functional vision was classified according to VFCS grades, that is 5 grades of visual function classification system. GDD was classified into mild, moderate and severe depending on the development quotient. So statistics, categorical outcomes were compared using chi-square test and Mann-Whitney. P-value of less than 0.05 was considered as significant. Median age was 2 and with interquartile range of 1 to 4 years. 66.7% were males. In our study, 13.3% were preterm and 86.7% were term on birth. So these were the associations of the global developmental delay. CP, where cerebral palsy and seizures were more commonly associated. In our etiology study, birth asphyxia came to be most common cause. So grading was done, and MRI findings also, according to birth asphyxia, HIE and PVL were noted. And these were the ocular diagnosis. CVA was like 47.8% had CVA and 27.8 had refractive error. So functional vision variables were also noted. And results, functional vision showed a significant correlation with the conventional vision, and there was association between severity of GDD and vision impairment. Also, associations like microcephaly and seizures had an association with vision impairment as said. In discussion, vision impairment goes hand in hand with severity of GDD, and conventional vision assessment poses a challenge in children with severe motor impairment, hence stressing the importance of FVA with CVA. So these were the limitations of my study. Conclusion, FVA is a valuable tool which helps to understand how the child uses visual function in various day-to-day hours. Also help in modifying the intervention and therapies also. Thank you.
No questions, sir. Okay, so with this, we have come to the end of this session. And on behalf of AIOS-ARC, I'm extremely thankful to all the chairman, co-chairman, and the judges, and request all of you to collect the certificates. So thank you, Dr. Sadil Kumar Mandan, for being the chairman of this session. Sir, would you like to give the certificate? Next, I call upon Dr. Smita Shukla, the co-chairperson of this session. No, it is not. Next, Kasturi. Next. And next.